Good evening, ladies and gentlemen. The lecture is about to begin. Please make your way to the Houston room. Thank you.
Hi, right. That's fine, thank you. Now. Okay, ladies and gents, could you take your seats, please? Welcome everyone to this James Mackenzie Lecture 2024. If you don't know who Sir James Mackenzie was, then please take a look at the collection that we have here at the front if you get your chance afterwards, because it includes some of Sir James Mackenzie's notebooks and various artifacts, including his knighthood medal, and also an interesting letter from William Pickles to John Hunt, arranging the first Sir James Mackenzie lecture in the 1950s, and asking whether the hall was big enough or whether we'd need to have some ticketing arrangements. So I'm glad to see you all here safely here this evening. I'm delighted to welcome everyone to this lecture. I'm Richard Vautry. I have the honour of being the president of the Royal College of GPs, and it's my privilege and honour to welcome you this evening. This year we're really pleased to be able to award the honour to Professor Kamlesh Khunti. Kamlesh grew up in a deprived area of Leicester City and studied medicine at the University of Dundee, where he qualified in 1984. He became a GP partner in a group practice, and in 1989, and within 3 years, he'd helped the practice become a teaching and a GP training practice. He was one of the first GPs in Leicestershire to be awarded the RCGP Fellowship by assessment, following which he helped his practice gain the RCGP Quality Practice Award. Kamlesh is Professor of Primary Care Diabetes and Vascular Medicine at the University of Leicester and serves as Director of Leicester Diabetes Centre, the UK National Institute for Health Research in Applied Research Collaborations at East Midlands, the Centre for Ethnic Health Research, and the Real World Evidence Unit. He leads a programme of work on cardiometabolic diseases and multiple long-term conditions. And he's recently been appointed as the director of the first NIHR Global Health Research Centre for Multiple Long-Term Conditions. He's the co-lead for the cross-NIHR collaboration for multiple long-term conditions, and he's the national NIHR ARC lead for multiple long-term conditions. Multiple jobs indeed. He's led a programme of work during COVID-19 pandemic and was a member of the UK Government Scientific Advisory Group for Emergencies, as SAGE, and was chair of the SAGE Ethnicity Subpanel. He's been cited at the top type 2 diabetes researchers globally and has published over 1,400 peer-reviewed articles. He is the chair of the American Diabetes Association Therapeutic Inertia Initiative, the National COVID Research Group, the National Diabetes Audit Research Group, and the HDR UK Ethnicity Coding Working Group, and the Office of National Statistics Ethnicity Working Group. He is a Fellow of the Royal College of Physicians, Fellow of the Academy of Medical Sciences, and Emeritus NIHR Senior Investigator. His work has earned him numerous awards, including the Lilly Global Leonard Award for Diabetes, the RCGP John Fry Award, the Diabetes UK Adrian Bloom Award, and the Sardar Vallabhya Patel Award for Excellence in Medical Research in India, and an Honorary Doctorate of Law by the University of Dundee in 2023. He was awarded the CBE in 2022. His main hobby, and he has time for a hobby, is spending time with his family. And we're delighted that members of his family have travelled all the way from the States to be with him this evening. It is therefore my pleasure to invite Professor Khunti to the lecture and to deliver the 2024 James Mackenzie Lecture and to award him the medal.
Thank you very much, Richard. Thank you, Camilla, distinguished guests, friends, and family. It's amazing they believe everything you write on a CV, isn't it? So my title today is The Social Determinants of Cardiometabolic Diseases in Ethnic Minority Populations. And it's a real honor and a privilege to get this award. So James Mackenzie was one of the giants of primary care research globally. And it's nice to see I have a little bit in connection with Sir James. He comes from a farming family. My grandfather and both my grandfathers were farmers. He had private tuitions in Latin. My parents gave me tuitions in Gujarati. He was trained in Scotland, where I was trained. He was a general practitioner in Lancashire. I trained as a GP in Lancaster. And he has an interest in cardiology, and I'm interested in cardiometabolic conditions. So over the next few minutes, I'm going to go through A few things about definitions, ethnic inequalities, possible reasons for these inequalities, ethnic minority representation in studies, and possible solutions for improving outcomes. I'm going to rush through a number of slides. I'm going to give you some top layer work that my group has done over the last 25 years and not go into much detail. So, ethnicity and race, what are the differences? Well, race is often distinguished on the basis of physical characteristics such as skin color, hair. With my hair, you can't really tell which race I'm from. However, in terms of ethnicity, this is mainly cultural characteristics such as language, habits, religious, and customs. And social determinants. WHO has great definition of social determinants. And these are income, education, unemployment, working conditions, food insecurity, childhood development, social inclusions, structural conflicts, and access to affordable health services of decent quality. So huge impact all of this has globally. In the UK, we have a free at point of service national health service, and we still see these inequalities. As a GP, you always start with a case study. So this is a case study of the index patient who I inherited many years ago, as I work in a very deprived area of Leicester. And he had, his father died of a heart attack at 54, his brother died of a heart attack at 46, his sister died of a heart attack at 56, and they're all diabetes. This is very common if you come to my practice, and those of you who look after ethnic minority populations, you'll see this. This comes regularly. So we got to know him really well. He had his first heart attack at 54, and then 65, then angioplasty, pacemaker, and then he had 2 strokes. So why is this that ethnic minorities get such a horrible phenotype? Well, let's look at some of the data. We really started talking about ethnic inequalities since the pandemic. Ethnic inequalities were there well before. They've been there for decades, but I think the lens has really shown on ethnic inequalities since the pandemic. And I'm glad to say that we, in our group, was the first ones to identify that risk and disproportionate risk among ethnic minority groups. We wrote, this is on the left-hand side, the editorial we wrote within the second week of COVID in the UK. And on the right-hand side, working with Jonathan Walabji and friends, we identified data and 60 million. That's another good thing we have in the UK, is the best data in the world, on 60 million patients, and showed that Black and South Asian population had an increased risk of mortality with COVID compared to the whites. This is the 2021 census. If you look at the data here, compared to the white population, which is the fourth one from the bottom, hypertensive disease, stroke, chronic ischemic heart disease, myocardial infarction, all of them 2 or 3 times greater in ethnic minority populations. This is not new. The same graph was there 2011, but we haven't been talking about that. So when does this risk start? Well, the risk starts possibly in epigenetic, possibly in pregnancy, but we started our work very early on in children. And here we went to primary care schools in Leicester and did anthropometric measures of these children. These were children with a mean age of about 12. At the age of 12, their BMI was similar to white patients, but they had a lot more body fat percentage when we measured it, which was significantly greater in the South Asian kids for the same BMI. And that's one of the landmarks and hallmarks of this increased risk. Then we went to inner city schools, 3,500 children, a very large study, and looked at their dietary and physical activity habits. As you can see, these inner city children from ethnic minority backgrounds had very poor diets and poor physical activity. If you look at the negative markers of diet, more likely to eat all of these are snacks eaten every single day. Okay? If you want to look at the right-hand side, physical activity, 46% of children were watching TV or on the computer more than 4 hours a day. And then we started a massive campaign in terms of screening in Leicester. I wanted to call it Stella, one of my favorite drinks at the time. Screening thoroughly everyone living in the Leicester area, but they said no. But we screened lots of patients in Leicester, and we saw that diabetes, impairs glucose regulation, cardiovascular disease, all of these were much higher in this population at a younger age. And some of this informed the National Vascular Health Checks program that we advised on, that we are still implementing. Another hallmark in terms of ethnic minorities is they get the disease much, much earlier. Type 2 diabetes, this is working with Sanjoy Paul. He's the statistician who did the UK PDS analysis. He's a good friend, and we looked at the routine data from UK. Age at which diabetes occurs in whites and ethnic minorities. Well, 58 for whites, 12 years earlier in South Asians, and 10 years earlier in black. BMI, much, much lower in ethnic minorities, and they live in the most deprived areas. HbA1c diagnosis, much, much higher in ethnic minority populations. So these people have had diabetes for a long time, but we haven't picked it up, and that's why the HbA1cs are higher. The other hallmark, and this is now coming to the forefront, is type 2 diabetes in the young. Type 2 diabetes in the young seems to be a more aggressive phenotype. They get complications much, much earlier, and they get mortality much, much earlier. And this study of ours showed that the prevalence of type 2 in the young is diabetes under the age of 40 was much greater in ethnic minorities, African, Caribbean, and South Asians, 20 to 30% prevalence compared to about 5 to 8% prevalence in the whites. We've also changed the way we diagnose diabetes. We used to do oral glucose tolerance tests. We've got HbA1c now. And we looked at the differences of identifying people using HbA1cs and oral glucose tolerance tests. This was Sam Mustafa, one of our PhD students, and we see that there are differences. If you use HbA1c, you identify a lot more people with diabetes, which is a good thing because we can do something about them. But there is a difference between those who identify oral glucose tolerance tests and those you identify with an HbA1c, but we know oral glucose tolerance test is horrible. I don't know if any of you have had it. I've had it done, and people are vomiting in our surgeries, so it's great to have HbA1c now. One of the reasons he identified was that South Asians have a greater glycated hemoglobin compared to whites once you've adjusted for everything. So it's 2%, 0.2% higher. So should we be thinking about lower targets for ethnic minorities? We don't have the data for that. Looking at the intersectionality between ethnic minorities and deprivation, this is again data Brianna Coles did from a large routine database in the UK. Is first of all again showing age at diagnosis is much lower in ethnic minorities, blacks and South Asians, but you can see that they're also more likely to live in deprived areas as well. Deprivation quintile being 5 as the most deprived area. They were less likely to be on lipid-lowering therapies as well. These were diagnosed people with type 2 diabetes, so they're not getting the cardioprotective therapies as much as they should be getting. Elpida from our group looked at gestational diabetes, and again we looked at gestational diabetes, which is much higher in ethnic minorities, and we looked to see progression to either diabetes, hypertension, or depression, and again identified progression was greater, significantly greater for South Asians to diabetes, significantly greater to hypertension for blacks. But depression was much lower, and I'll come to that later. The reason we see depression being lower in all databases and GP practices is because we're not diagnosing that. And I'll show you some data why we may not be diagnosing that. We call it lost in translation. This is looking at data for 5 million people. As I said, we have the best data in the world. This is everyone admitted to an English hospital. This was 5 million people, first cardiovascular event. And again, when you look at this, mean age at heart attack or cardiovascular event for people with type 2 diabetes in the white population is 73. South Asians is 10 years earlier. Blacks about 4 years earlier. When you look at it in people without type 2 diabetes, mean age for whites 69. South Asians get it during their working age lives. Blacks get it during their working age lives. So significant impact on work and pensions for these populations. In terms of the policies that we've put into practice, QOF, or pay for performance, many of you know, has been put in there to reduce inequalities. So working with Azim Majid's group, we looked to see if QOF has reduced disparities. And this is 2 years after QOF was introduced. And you see that overall, it didn't reduce disparities, maybe possibly widened them. So people achieving a target of less than 7.4% for HbA1c was not achieved for ethnic minorities compared to the white populations. And particularly in terms of South Asians and blacks, you were less likely to meet all three targets of blood pressure, HbA1c, and cholesterol. What about once you've diagnosed people and you go on to escalate therapy, put onto people onto therapies? So Yogini, our PhD students, looked at this to say, is there this thing called clinical inertia or therapeutic inertia, failure to advance therapy when appropriate to do so? And again, we see, compared to the white population, black population are less likely to have an intensification of therapy at an appropriate time. So not only are we diagnosing them late, not managing risk factors, but even the glucose-lowering therapies are not being initiated in a timely manner. What about prescriptions of the organ protective therapies we have? We have fantastic therapies, GLP-1 receptor agonists, SGLT2 inhibitors, all of them have remarkable data of reducing outcomes, kidney outcomes, heart failure outcomes, and mortality. And again, when you look at this, this is again not limited number of patients. This is the whole population of type 2 diabetes in England. 2.8 million, nearly 3 million people. And what we see is that, again, Asians and blacks are less likely to get GLP-1 receptor agonists. Blacks less likely to get SGLT2 inhibitors. And South Asians more likely to get sulfonylureas, which I still use, but higher risk of hypoglycemia and weight gain, as you all know. This is work we did with London School, again showing similar. This is more recent data, the same pattern still emerging. And again, there's the issue of intersectionality. When we look at sulfonylureas, DPP-4 inhibitors, there doesn't seem to be a difference between ethnic groups in terms of their prescriptions. Where we look at by socioeconomic groups, again, we don't see a difference. But when we come to SGLT2 inhibitors, the organ protective therapy is significantly less likely to be prescribed in ethnic minority groups and socially deprived populations. We've done a huge amount of work on body composition and obesity cut points among UK Asians and whites, as well as comparing them to the Indian cohorts. So let's just give you an example of what this difference is. This is the glycemic load. What's your glycemic load of a person at a given BMI? So on the right and at the bottom, you see the BMI. So BMI for a white person is in the red. Your glycemic load is 0, is what you would expect if they were equivalent. So at the BMI of 30, ethnic minorities, South Asians, get the same glycemic load at a BMI of 23. Okay? So you get the higher risk at a BMI of 23. So you should be classed as obese. BMI of 30 in a white is obese. South Asians should be classed as obese at a BMI of 23. I'm sorry, all you South Asians, you're all obese. But we do not put that into publications. We do not put that into NICE guidelines. This data informed the NICE guidelines on BMI and waist circumference because there's no one's going to achieve a BMI of 23. We're on a failure. So we opted for 27.5, and that's what you see in routine practice, that if you start GLP-1 receptor agonist, bariatric surgery, you have a 2.5 less, but it should be really much, much lower. We repeated that data during COVID. And again, this is data working with ONS, large data, whole population data. So on the left-hand side, what you see is the risk of COVID-19 mortality. The bottom line is white populations. At the top is the ethnic minority, blacks and South Asians. Much, much higher risk going up at a BMI around 24. But South Asians are younger. So when we adjust for this, you see on the right-hand side, the hazards start going up at a BMI of 23. So again, COVID association was at much, much lower BMI compared to the white population. So coming to the future, what's our next challenges going to be? In terms of challenges, transition of diabetes has occurred over these years. 1960s and 80s, we had low prevalence of diabetes. We had improving care during the 2010. Then we started peak incidence and stagnating of complications. But now we're thinking about multiple long-term conditions. That's the next pandemic or epidemic, whatever you want to call it, we're going to get. And I'll show you some more data on that. So this is again data for 60 million people, the whole population of England. We worked with Jonathan Walabji on this. At the top, you see on the left top A, you see by age. The orange line, it varies depending on where you're looking at it. The second from top line is the proportion of people having multiple long-term conditions, more than 2 chronic conditions. And as you can see, it's not in the 60s. You start getting multiple long-term conditions from the age of around 30. No differences by sex. Deprivation at the same age, deprived population have twice as many multiple long-term conditions as people in the least deprived area. And for the first time showing that ethnic minorities have a lot more multiple long-term conditions, the white population, again, increasing from the age of around 50. The mean age of white population was around 45. The mean age of ethnic minorities in England was about 35. So what are the possible reasons? Well, I don't want to tell you those because I would stop working then, wouldn't I? We really don't know. There's been lots of things that have been talked about, and it is very complex. There is no one single reason for this increased risk. Nitin Golab, another one of our colleagues, did a very good review on this. And there's lots of things, all the way from body fat to migration, to genetic factors, to diet, lifestyle, and environment is another reason that is increasingly being looked at. So during COVID, we looked at the reasons for the increased risk of COVID and COVID mortality. And this is what we came up with: poor control measures, worse social environment, increased exposure to the virus, and increased vulnerability to disease. Well, we've known all of this before. Take COVID out and make it cardiometabolic diseases. We've got the same factors affecting ethnic minorities: poor control measures, worse social environment, increased vulnerability to disease, and increased exposure to risk factors. So you could easily see that this was already happening before COVID, but it's really shown a light that we need to do something about this. There's ingrained range of attitudes and illness beliefs, mainly because of poor education attainment in ethnic minorities. And these are really, really difficult to change. So we need to look at culturally adaptive self-management interventions. These are the attitudes which are so difficult. So these are studies we've done, qualitative studies. When you ask people about diabetes and getting cardiovascular disease, say, because of our different cultures, we worry about our children and the future. In the past, we used to live together, share our worries, but now you're on your own. So there's been a transition of how people are living here compared to when they were living abroad. My dad was a diabetic, but he has passed away now. My mum is a diabetic, so I knew all along that I would end up. When we tell a white European that they've got diabetes, there's a sense of bereavement. You tell a South Asian they've got diabetes, say, well, I was going to get it because everyone had it. Right? How do you change those attitudes? It's all to do with God, so blame someone else, whether you get diabetes or don't get it. Coming to identifying certain factors that are not easily measurable. When we use the right tools to ask the questions, you get much higher prognosis. So this is where Cameron Razia from our group looked at the UK Biobank, where they asked the population of the questions of depression. And suddenly you see, after you're adjusted for everything, depression's higher. But when we look at routine data, GP data, it's much lower because we're not identifying it and then not coding it. There's also unique barriers to lifestyle interventions as well, particularly among South Asian patients. There's barriers to certain therapies. Injectable therapies are frowned upon because they think their ancestors had diabetes and they were given injections and they died, and they thought it was the injection that killed them. So again, this is all to do about education. Education of people with type 1 and type 2 diabetes and the healthcare professionals, getting the confidence to give that feedback to the patients. Environment. We don't take much care of environment. Environment is a major, major risk factor. So here what we did was we did the screening study across Leicester and had data on diabetes, pre-diabetes, HbA1c's on population of Leicester. We geomapped that to the postcodes of all the outlets, the takeaways and the restaurants, and did some modeling, and it showed that there were more fast food outlets in non-white areas and socially deprived areas where ethnic minorities resided. And after adjusting for a number of factors, fast food outlets were associated with significantly odds over diabetes. So every additional 2 outlets per neighborhood within 0.5 kilometer radius was associated with an additional case of diabetes. It was all over in the newspapers in Leicester, and then the council made a decision that they weren't going to approve any fast food outlets, and my kids told me to keep away from those areas, as they had a contract on me, they said. Are there biological differences? Well, there may be, we don't know. So this is looking at data, Alison Dunkley looked at this, of risk of hypoglycemia in people with type 2 diabetes. And for some reason, we get lower risk of hypoglycemia in ethnic minorities. Now, we're not sure whether this is a biological factor or because they are not getting the symptoms, and they don't come up with the symptoms exactly like the white populations do. That's where all the research has been done. We've seen this with chest pain as well. We've looked at chest pain, and ethnic minorities, particularly South Asians, don't get the classical risk factors or classical story about tight chest pain, sweating. They come up with very, very different risks and the way they describe their diseases. And that's why they're late getting to ambulance and into the hospital. Therapies. There are large variations in how therapies work, but we don't test them separately. I'm not asking for trials to be done separately, but when the trials are done, they should report ethnic minority data separately. And this is data that Sam Saidu, sitting here, and our group looked at, showing that the SGLT2 inhibitors and GLP-1 receptor agonists I mentioned may work differently in ethnic minorities. This is the first time it's been shown. So if you look at the top in white populations, these novel therapies, SGLT2 inhibitors, you get about 8% reduced risk of cardiovascular outcomes. But in Asians, there's a much greater risk reduction. In blacks, it doesn't seem to work as well. Now, we don't know if these are biological mechanisms here at all. That's not been tested. And these are all things that we need to look at. What about studies in cardiometabolic health? Well, again, these are not reported. This is a systematic review conducted of 12 studies of these organ protective therapies. First of all, ethnic minorities are underrepresented in studies. And secondly, when the data are there, they're not reported. So we need to caution exercise in terms of translating these studies into our populations that we look after in primary care. This is a student with us who looked at multiple long-term conditions. And diabetes, cardiovascular disease are the 2 commonest multiple long-term conditions with depression. And again, not many studies, first of all. Secondly, only 4 of the studies represented ethnic minorities and reported them. Most of them included white participants, and ethnic minorities were underrepresented. Even socioeconomic groups were not represented as well. Another study from Murali from our group looked at meta-analysis of enrollment to COVID-19 trials and compared it to the ONS, what proportion of people of South Asian and black origin who reside in the UK. And as you can see, overall COVID-19 trials underrepresented ethnic minority groups. And the main reason is, and again, we've looked at this during COVID, so what are the views of minority groups and vulnerable population, not just minority groups, but mental health problems, people with homelessness, people of Gypsy, Roma, travelers, they all have different barriers. And we need to look at all those barriers. And as I say, this is COVID, but it's the same for physical activity interventions, it's the same for dietary interventions. We need to identify what are the key barriers and adjust whatever interventions that we're promoting for that group. Ethnicity coding is very, very poor. If we don't know the ethnicity coding, we don't have data, we can't see if there are differences. And then if we put any interventions in, we can't tell whether the interventions have worked or not. So this is something that we are strongly promoting. So that's all the bad news. Now coming to some of the potential solutions. First of all, language of ethnicity needs to change. I still see people using the word BME or BAME. Those are words that ethnic minorities do not like. They want to be called by the ethnic minority that they represent. So we should be calling them black populations, South Asians, if possible, Bangladeshi population, Pakistani population. But when we're talking about them collectively, then the word that should be used is ethnic minority populations, not BAME or BME. And this is something that's changed through the government, which is really great news. So even the government documents now say we should be using that word. We need to identify people early and intervene early. As I said, ethnic minorities get diabetes much, much earlier. So we've done a huge amount of work developing risk scores for early detection of diabetes. And we're pleased that our risk score was recommended by NICE as well as 2 other risk scores, and our risk score is on the Diabetes UK website. I know Chris is here promoting that when he was at Diabetes UK. And over 3 million people have assessed their risk here. It's a simple risk score, simple measures. And we've now translated that into a number of languages. And that's also available freely at Diabetes UK website. The problem is that translation is not what we know about forward translation and back translation. There is no, that does not work. So when we translated these, it took 8 weeks to translate into each language. One of the questions in there is BMI. There is no word for BMI in ethnic minority populations. No word in BMI that I'm aware of in South Asian language. We have the same problem with many other things, such as when we're talking about prostate cancer. There's no word for prostate. So I have to use some rude words when I'm talking with our communities there. So the Holy Grail is precision medicine, genomics. That's what's going to solve the problem. Well, it ain't. This is data we've looked at on the left-hand side. Biobank, a genetic risk score. Compare that to our risk score that we've developed. As you see, clear line overlap. The genetic risk score did not give us anything additional to the risk factors that we're already using in our risk score. On the right-hand side, we've just published with Nilesh Samani a polygenic risk score for cardiovascular disease. Again, doesn't seem to work brilliantly well compared to the Q risk score that we use, except for in the younger population, because their lifetime risk is much, much greater. And so it may be useful in the younger population, but the population over 40 or 50 doesn't really make a difference. So what we're doing now is the right thing. But what we need to do is identify these people and put them onto the correct treatments. Education programs, it's all about education, education, education. We've been very privileged to have worked with our population, develop the Desmond program. It was the largest randomized controlled trial done for education for people with type 2 diabetes, shown to be highly cost effective. And that's been promoted across England, Wales, and other countries as well. But unfortunately, the uptake is much, much lower. We adapted this for African, Caribbean, and ethnic minority South Asian populations as well. And the problem is that we need to look at that individual and offer an education program that's appropriate and preferred education program, that population. So this is Quinn and Kate who did this work from us, looking at a large survey of people who could have had cardiometabolic education programs. As you can see, found a number of clusters, all differences. Everyone needs a different tweaking. Some want a group education, some want one-to-one, some want a paper-based, and some don't want any at all. And those who don't want any at all, we need to work with them to get education programs say it is important for them to update these. Digital interventions are going to solve the problem, but again, there are major problems with this. And this is a systematic review we did with Ami Banerjee in London, showing that at all stages of development, we need to have that population that we are targeting in mind, all the way from early stages to initial usage and continuation usage. We know there's a lot of emphasis on using and a lot of interest in using it initially, but within a few months, that intervention wanes. And continued use is something that is important to look at right from the start when we're developing digital interventions. We need to be innovative about the way we convey our messages to ethnic minorities. So these are some of the programs that our group's done. Asians love DVDs. So we've developed DVDs for the elderly Asian populations. We worked with Leicester City Football Club. Yes, we did win a championship once. And they've been great. So we have a Healthy Goals program where, as you can see, the Asian ladies at the bottom, they go to the Leicester City football ground to do physical activity interventions. And we worked pre-Ramadan for safe Ramadan programs in our mosques. When we're developing materials, we really need to think about our target population, because, as I said, forward translation, back translation doesn't work. And this is a clear example during COVID. So ethnic minorities had high prevalence and incidence of COVID and mortality. But when you look at long COVID, there's a much, much lower prevalence. And the main reason is the symptoms that ethnic minorities have are very vague, very different to the white population. Tiredness, every one of my aunties has tiredness. But the nuances are really lost. And so we need to work much, much harder at developing specific programs and translating them to ensure that we're capturing the true essence of the symptoms that they're presenting with. And there are communication barriers when we're translating these and working with our population. Again, there's training needs for there. Written material is something that many ethnic minority populations like, and this is something we did during COVID. We developed a program for prevention and interventions for uptake of vaccinations, and these were published in about 6 languages. And these are being used globally. People from India downloaded these and they were using them as well. Again, education programs, if appropriately developed with that population in mind, we work with them initially to develop these, there will be higher uptake. So this is something we've done with the gestational diabetes randomized controlled trial of over 300 women. 40% were ethnic minorities. So we can get a product that is acceptable to ethnic minorities. And this showed that you increase your step count by about 500 a day. 500 steps a day doesn't seem a lot. That's all you need to reduce your cardiovascular risk by 10%. Improved quality of life, reduce anxiety, increase self-efficacy for exercise. It was highly cost-effective. Sleep is something we don't talk about much. There's a lot more interest on sleep and physical activities. This is work from our lifestyle group. And if we look at moderate to physical activity, South Asians and blacks have lower moderate to physical activity. South Asians, blacks have similar. But sleep variability is much, much worse in South Asians and blacks. And we know both of these are associated with increased cardiovascular risk. But we can do interventions, simple interventions, to improve outcomes. So this is Tom Yates, one of our PhD students who's now a professor in our group, has been doing very intensive exercise interventions. And let me take you through on the left-hand side and then the right-hand side. Left-hand side is looking at insulin resistance index. On the right-hand side, insulin sensitivity. And what we did here was look at low volume, high intensity interval exercise and continuous moderate intensity aerobic exercise on the left-hand side. And these little low volume exercises improved outcomes for South Asians a lot more than the white populations. South Asians don't exercise as much, but when they do, they get better benefits than the white populations. On the right-hand side, doing simple things. looking at normalized insulin sensitivity, much greater effect just on standing and walking for South Asians compared to the whites. So these are simple things that we can put into our normal everyday practice. Having guidelines, appropriate guidelines at the right times is also important. And these are recommendations for Ramadan, for example, that we've been working for many years with our communities. Access to research and increasing participation. Leicester, during COVID, the Leicester hospitals recruited more patients from ethnic minority populations to COVID trials than the whole of England put together. And the reason was we were ready for this. Our communities were ready for this. Our teams were ready for this, to do the translational work and approach these patients who were in hospital or in the community. And we have our Centre for Ethnic Health, have a number of programs that are being used nationally and locally. We need to improve inclusion and diversity. This is a commissioned work to us from the Department of Health. So how can we increase ethnic minority participation in research? And there's lots of things we can do. Simple things like logistical barriers to get there. Giving bus tokens or taxi tokens for research. And these are all available and funded by the research funding bodies. Building community partnership is something that we're doing. Going through faith centers, we recruit a large number of patients by doing simple things. We've done a cardiovascular outcome trial called the Addition, working with Cambridge, Leicester, Denmark, and Netherlands. Cambridge had the same leaflet, our traditional way of going through a GP practice. The letter goes to the patient, and you get a response rate. They were getting a response rate of 40%. In Leicester, we're getting a response rate of 5%. Same leaflet. So traditional methods don't work in recruiting these participants, and we need to think about more innovative methods. Ethnicity coding is so important, and we should be coding within our practices, within our research, at least to the 5 level of coding. That's at the bottom. If possible, 9 level. ONS does it to 18 level, which is quite difficult, but that's been done by ONS. But linking that data to primary care is not possible. And so we are working nationally to see if we can link these data. Multiple long-term conditions is, as I said, the next phase that we are facing. And we need to start thinking about working with these populations differently. The patients come not with one disease. We still have that traditional model of a diabetes clinic, a cardiovascular clinic. And Sam and I started a multiple long-term conditions clinic, I think about 10 years ago. It seems to work extremely well. People with 3 or more conditions come for a much longer appointment. But they haven't been evaluated well yet. So we need the science behind that as well. Shouting about what's important, and this is working with Diabetes UK, we identified gaps in research and the research priorities among South Asian populations and black populations. And they have been taken up by funding bodies in the UK and outside of UK as well. But really, we need population level strategies to improve these social determinants. So there's many actions, as you can see in the red, short-term actions that you and I can do. Improve preventative uptake, collection of routine data, increase screening at a younger age, culturally adapted management materials, assess remote access that doesn't increase disparities, and strengthen science. This is all something that you and I can do. But the blue circles are the ones that really the policy recommendations need to be taken on. Improving education, investment in housing, and improving employment are the kind of things that really are going to reduce these disparities. So in summary, there's growing evidence, this has been present for decades, that there are marked ethnic inequalities in cardiometabolic diseases. This is despite our universal access to National Health Service, and we're very, very privileged to have that. The precise reasons are not known, but there's no single reason there. Culturally tailored education programs are likely to help, but we really need to look at the vital social determinants, and we need a multisectoral approach here, supported by strong policy action, and also more money for inclusive research. So I'll just a take-home message of what we could potentially achieve. This is a modeling study we conducted. looking at COVID-19 positivity, COVID-19 severe disease in the middle, and COVID-19 mortality. If we got 25% of the most deprived population out of deprivation, we would reduce the risk of all of these by 50%. If we took the 50% of the most deprived population out of deprivation, we would eliminate these disparities completely. And I think that's the case also for long-term conditions as well. Professor Sir Nilesh Chamani and I wrote this 20 years ago, that this epidemic is not new, is not old. This has happened in the last few generations. So if this epidemic of disease in South Asians and blacks is a disease of migration, has occurred within a generation, there's no reason why we shouldn't be able to reverse this within the same timescales as well. So let me come back to the patient. Unfortunately, he died at the age of 79. He was very close to us as a family. So what do we do for the next generation? What do we do for his two sons? Well, he shared this photo with me. This is where his son was born. This is corrugated iron houses in the slums of Africa, in Uganda. On the left-hand side, you see a little toilet and a bathroom shared by 10 houses. So what do we do to improve the outcomes for this young child? Well, we need to change the environment. And that's exactly what happened. He became a slumdog researcher. So, what should I be doing for myself and my family? Well, as you've seen, I'm into evidence-based medicine. And I've heard exercise is good for you. And I've heard alcohol's good for you. And being a researcher, you think you might have a multiplicative effect. So that's what I do. What should I do for my children? Hopefully alcohol will work there as well. That's my daughter Nitisha there. And please don't tweet this. I'm not a irresponsible father, there was no alcohol there. Right. A few thank yous. Thank you to Professor Melanie Davies. I've been working with her for many, many years, and we've formed a good partnership. She's in secondary care, I'm in primary care. And we have the largest diabetes research group in UK and second largest in Europe now. And these are the senior team, and Sam's been with me for many, many years. This is the most of the group here. And it's great that we don't just do research, we try and implement it in practice as well, with education programs underpinning all of these. These are my collaborators, UK and abroad. These are my PhD students, as you can see, number 25 there, I think, is Sam Saidu, sitting here. These are my funders. Thank you to all of them. But this is what keeps me going, my munch. They're only here because they heard there were free drinks and food. And I'd like to thank them all individually. So, Prima, my wife's been with me, put up with me since I was 18. I have 3 children. Nitisha, Sachin, and Nell. And their partners are here. Thank you. Akshay, Anika, and Ravi. And we now have a grandchild. And as I said, they keep me going most of the time. I'd like to say thank you to my slumdog parents. I'll leave you with a Hindi song, which is one of my favorite songs. It's called Zindagi Ka Safar, Hai Ye Kaisa Safar, Koi Samjha Nahi, Koi Jana Nahi. It's a journey of life. What kind of journey is it? No one has understood it, and that no one comprehends that. And I'm not sure how I got here, but I did get here. Thank you very much for listening.
Kamlesh, thank you very much. You said that your favourite drink was Stella. Well, I think we've had a stellar lecture this evening, and we are so grateful, not just for you bringing your research to us today, and clearly your passion, your real passion for this subject as well, to make a difference not just for your family, your friends, your patients, the population, indeed the world, in what you are trying to do. And I think one of the key messages as well at the end was there is more research needed, and we are really grateful that you are there involved in training researchers and involving people in research, and we're grateful to play a small part in that as well. So we're really grateful for you taking the time, for you to lecture us today, for you to be with us today, for your family to be with us as well, to support you. And we wish you all the very best in all that you continue to do, and every endeavour. We wish you well, and thank you very much again. Thank you. So just a reminder for those who've maybe came late, there is a small display at the front of artefacts relating to Sir James Mackenzie. Please take a look at that, but just be careful with them. They are old, and just be careful not to take them home accidentally. Otherwise, our archivist will be after you. We're now going to retire across the way to pick up some food, but then please bring it back in here to eat it and share with us, and share in conversation and fellowship with one another. Thank you very much.